Let's be real. If you've ever felt completely overwhelmed by pediatric congenital heart defects for the NCLEX, you're not alone. It is, hands down, one of the toughest topics out there. But what if there was a way to make it all just click? Today, we're going to pull back the curtain on a framework that turns this super complex subject into a simple, actionable plan for the NCLEX. Let's dive in. Okay, first things first. Let's get this straight. The NCLEX is not playing a game of name that murmur. It's so much bigger than that. It's about getting the why behind the what. When you hear that whoosh, what is actually happening to that child's oxygenation, to their perfusion? That's the question that gets you the points. And yeah, the pressure is on because the stakes here are incredibly high. In the real world and on that exam screen, missing those tiny, subtle signs of low oxygen can be the difference between a pass and a fail, and life and death. This is where your clinical judgment isn't just a buzzword, it's everything. It's about patient safety. So what does all this mean for you? It means success on this exam is not about being able to recite a textbook. It's about knowing what to do. When crisis hits, what's your first move? What are you watching like a hawk? How do you respond when it all goes sideways? That's the kind of thinking we're going to master. Okay, so you might be wondering, all right, I get it. So why does this topic still feel like I'm trying to climb a mountain in flip-flops? And trust me, if you're feeling that, you are in good company. Let's break down exactly why this section is such a beast for so many people. Does any of this look familiar? Your brain is swimming, trying to keep track of which defect increases flow and which one decreases it. You're terrified you're going to miss that one subtle sign of heart failure. You've memorized all the names, ASD, VSD, TOF, but when a scenario pops up, you freeze, not sure what to do first. If you're nodding along right now, I'm here to tell you there is a much, much better way. And this right here, this is the secret sauce. This is the game changer. We are going to stop trying to memorize a mountain of individual facts. Instead, we're going to focus on patterns. Because once you see the patterns of blood flow, everything else just falls into place. It's like getting a master key that unlocks the whole topic. Ready to see it in action? Good. Let's jump into part 1 of the framework. We're going to start with all the defects that have one major thing in common. They're sending way too much blood on a trip to the lungs. So here's the core principle. Just think basic physics. The left side of the heart is a high-pressure system. It's like a fire hose. The right side is a lower-pressure system. So if you pop a hole between them, where's that blood going to go? It's going to shunt from left to right. And where does the right side send blood? Straight to the lungs. So left to right shunt, your brain should immediately scream pulmonary congestion and heart failure. Now look at this. We've got two kinds of holes here, an ASD between the atria and a VSD between the ventricles. But do they act the same? Not even close. An ASD can be totally silent for years, but a VSD? That can cause major problems fast. And why? It's all about pressure. The ventricles squeeze so much harder than the atria, so that pressure difference creates a much more powerful, dramatic shunt with a VSD. Okay, NCLEX mode on. You've got an infant with a known VSD. Suddenly, they're breathing fast, they don't want to eat, you see some retractions. What is your absolute first priority? What's the one thing you need to be monitoring that signals this is getting worse? This is exactly how the NCLEX thinks. All right, we just covered what happens when there's too much blood flow to the lungs. So, let's flip the script. What happens when there's not nearly enough? Welcome to part 2 of the framework, defects with decreased pulmonary blood flow. So with this one, the whole system is backward. Think of it like a roadblock on the highway, out of the right side of the heart. Traffic backs up, pressure builds, and that deoxygenated blue blood has to go somewhere. So it spills over to the left side and gets pumped out to the entire body. Right to left shunt, your brain immediately needs to picture a blue cyanotic baby. So your patient is blue. Now what? You got to be a detective. This is where the framework is your best friend. With tetralogy of Fallot, you're on the lookout for those sudden, dramatic TET spells, especially when the baby is crying or feeding. But with tricuspid atresia, that cyanosis is deep and it's constant. It's always there. See the difference? The framework helps you spot those crucial clues. Oh yeah, this is a classic NCLEX emergency. A kid with tetralogy of Fallot is having a TET spell. They're turning blue right in front of you. What do you do right now? And I don't just mean grabbing an oxygen mask. There is a specific life-saving action you need to take first, and you can bet the NCLEX wants to know if you know it. Okay, so we've done too much flow, and we've done too little flow. You ready for the final category? What happens when the whole system is just a complete mess? That brings us to part 3, the mixed defects. Just imagine taking red paint and blue paint and just stirring them all together. You don't get red or blue, you just get this purplish mess. That's what's happening here. Oxygenated and deoxygenated blood are totally mixing. And the result? It's the worst of both worlds. You get a wildly overworked heart, leading to severe heart failure, and you get unpredictable, variable levels of oxygen. And this is where your detective skills are critical. With transposition of the great arteries, or TGA, that baby's survival literally depends on keeping a tiny little shunt open. It is their lifeline. But with something like Truncus arteriosus, you've got a whole different problem. One giant vessel where there should be two. The framework helps you know what to look for and what matters most in each one. All right, here's a top-tier NCLEX question for you. Infant with TGA, oxygen sats are in the toilet. You put them on oxygen, and nothing happens. The numbers aren't budging. What is your priority action? This is where you have to think past the obvious. The answer isn't just treating the symptom, it's fixing the root cause. Okay, let's zoom out. We've gone from increased flow to decreased flow to totally mixed flow. It sounds like a lot to juggle, I know. But here is the truly beautiful thing about this framework. No matter which category you're in, the unifying principle, your core job as the nurse, is exactly the same. This right here is your new mantra. Write it down. This is your North Star for any peds cardiac question that comes your way. Your job is to spot trouble early, know how to prioritize oxygen and perfusion, and then act safely and with confidence. That's it. And that's the real power here. We're not just about teaching you a list of heart defects. Honestly, at Exam Coaches, we don't believe in just dumping facts into your brain and hoping they stick. No, we train you. We train you to recognize a complication before it spirals out of control. We train you on priority interventions so they become muscle memory. We build that NCLEX level clinical judgment piece by piece so you can walk into that exam and feel ready for anything. Because when you're sitting in that testing center, remember this one simple truth. The highest scoring answer is always the safest and most timely action for the patient. That's the game. And this framework trains you how to win it. Look, everything we just went over, this was just a peek behind the curtain, a little preview. The full, in-depth pediatric cardiac framework is waiting for you inside Exam Coaches. So, if you're ready to take your clinical judgment to a whole new level, you know exactly what to do. Let's get you ready to crush this exam.